Hi and welcome to the Women's Handbook podcast, How to Be a Woman, where we are filming direct from the 2025 World Endometriosis Congress in Sydney. I'm your host, Dr Natalie Hutchins, and today we're going to be talking to some of the experts that have been speaking here over the last couple of days, just to make sure that you get some evidence-based information direct from the source. We are going to be speaking about nutrition, lifestyle, psychological therapies, self-management techniques, endometriosis and cancer, and much, much more. So let's get started. Okay, so first up I'm joined by Dr Siew Lim, who is a dietitian and also a senior research fellow at the Monash University, and we're going to be talking about diet, lifestyle and endometriosis, which is a huge topic. Welcome, Dr Siew Lim. How are you?
I'm very well, thank you.
Thank you so much for joining us today. I know that you're going to be talking later, and I know that we haven't heard it yet, but I wonder whether you'd give us a sneak preview of the contents of your talk later.
Sure. So my talk is on lifestyle disease prevention in endometriosis. So this might not be known by very many people, but women with endometriosis are actually at increased risk of developing heart disease. And that's because of the key role of inflammation in the development of endometriosis.
Right.
And that same pathway also leads to things like insulin resistance, metabolic syndrome, and cardiovascular disease in the long run.
Goodness. Yeah, I mean, I think that's definitely something that's not talked about enough. I think there are actually quite a few female-specific cardiovascular risk factors, aren't there? Like
Absolutely.
Gestational diabetes in pregnancy, polycystic ovaries, but I don't think it's that well known that endometriosis is part of that. So you talked about inflammation. Can you tell us a bit more about that and how it affects cardiovascular disease?
So the common pathway that links endometriosis to cardiovascular disease is on inflammation. So inflammation is part of the initiation and progression of endometriosis. It is also part of the initiation and progression of cardiovascular disease in that the inflammatory cytokines actually causes endothelial dysfunction that leads to plaque formation, which is what leads to heart disease.
Right, goodness, okay. And you talked about prevention, so I'm hoping that you're going to say that there are ways that we can kind of mitigate that risk, either through lifestyle or diet. Is that what your talk is focusing on?
Very much so. So it's actually quite well established in the general population that certain dietary patterns is associated with decreased risk of type 2 diabetes and cardiovascular disease. But this evidence is actually lacking in endometriosis. So part of my talk is actually the main point of my talk is actually to highlight the evidence gap and a call out for researchers to actually address this evidence gap, because we really do need to find out effective diet that can actually manage endometriosis in the immediate term, but also to mitigate these long-term risks of cardiovascular disease prevention.
Absolutely. I mean, I think if you open social media, you're just awash with diets, special diets for endometriosis, claims of diets being anti-inflammatory, claims even of cures for endometriosis. And you talked about the lack of evidence. So where does the evidence lie? Can we actually say that a diet does have evidence base for being anti-inflammatory, or is that just a social media myth?
You know what's the shocking thing that I found in my literature review is that there is actually currently no randomized controlled trial at all on dietary intervention in endometriosis. So whatever recommendation that we can provide to women about or to individuals on managing endometriosis is actually based on indirect evidence. So we really do need evidence that actually underpin the recommendation of what is the best diet for endometriosis. So looking at the general population, though, we do have anti-inflammatory dietary patterns that's actually quite well established that could actually reduce cardiovascular risk. So it generally looks a little bit like the Mediterranean style diet, which is high in whole grains, fruits and vegetables, largely plant-based, and with very low levels of saturated fat, trans fat, and added sugars.
Okay. And obviously that would help. That's got good evidence in the general population of helping prevent cardiovascular disease and diabetes. Do you think that type of diet would also help prevent or help with the symptoms of endometriosis as well?
There's actually been a small study looking at Mediterranean diet and endometriosis, and they did find an improvement in the symptoms of endometriosis, particularly in the management of pain, which is very important in the management of endometriosis. But because that study is really small and it is an uncontrolled study, so it's not really gold standard evidence, we really do need to try out Mediterranean diet in endometriosis to be able to conclusively say that it works for most individuals with endometriosis in general.
Yeah. I mean, I think, and as you know, because I know that you've performed a survey looking at how patients with endometriosis actually self-manage with diet. And I think everyone in the endometriosis community, I mean, it's so common for women to actually try dietary changes to help. And actually there was this survey published in the JAMA recently that talked about women, about 80% of women trying dietary changes, and actually up to half of them seeing an effect. So even though the evidence is not there, women are still taking this on themselves to try and find something, anything to help, given the lack of options for endometriosis patients aside from hormonal therapies and surgery. Do you see that in your own practice that women are indeed trying to use diet to help with their symptoms?
I think what you've cited there would be a very good snapshot of what actually happens in the community, where women are actually desperate and actually trying all sorts on their own, despite the lack of evidence of what actually works. I think if we talk about consumer-driven research agenda, it doesn't speak more loudly than this.
Absolutely.
That really is a very urgent need to actually provide the evidence to run the trials on what actually works for endometriosis.
Absolutely, because I think one of the risks of this is that women end up going on very restrictive diets, being very confused about what's happening, what they should be doing, and end up causing, problems with kind of perception of food and their relationship with food. So I think we absolutely are crying out for the research to help guide women on what they should and shouldn't be doing. I mean, I think there are a lot of women also who will exclude things like dairy and gluten, and some will get a benefit, although this isn't evidence-based. What do you make of that? What are some of the mechanisms that, may be explaining why these women are getting some benefit?
I think given the key role of inflammation and immune response in the development of endometriosis, because these are also the common pathway of developing food intolerance. So it could be true that a lot of women with endometriosis also actually have food intolerance at the same time. So that might explain why some of this exclusion diet actually works for, in terms of relieving symptoms in some of these women. But one thing that I'd like to point out is that many times we think twice about trying a new drug, but we don't think twice about trying a new diet. But trying out new diets, especially some of these exclusion diets, which are highly restrictive, are not without risks. For once, a lot of these diets are so restrictive that it's probably not feasible in the long term anyway. And secondly, if you do manage to stick to it in the long term, you might run into other problems like micronutrient deficiencies.
Absolutely. I think certainly what I've seen on social media is that there is a lot of emphasis on what you take away from your diet, but there isn't necessarily so much emphasis on what we should be putting into our diets to make them healthy and have an anti-inflammatory focus. So if you were speaking to a patient about endometriosis and diet, what types of things would you be encouraging them to add in?
Very good question. I think our best bet at the moment, given there's no direct evidence, our indirect evidence on anti-inflammatory diets tends to be a diet which is really colorful, with lots of antioxidants, lots of fruits and vegetables, whole grains, largely plant-based, a healthy amount of healthy protein, a good amount of healthy fats, and a limit on saturated fat, trans fat, and sugars. I would think that that's the best bet we've got in terms of maximizing the anti-inflammatory state of our body.
Absolutely. And I'm sure you're very much like me in that when you get a patient in, often some of the conversation will go to supplements. Everyone wants to know what supplements should I be taking. What's your stance on that?
Yeah, the best evidence we've got to date is on the combined therapy of vitamin C and E. There's been a meta-analysis which actually combined studies that on that particular topic that actually show good evidence on a combined therapy of vitamin C and E being quite protective in terms of managing pain in endometriosis. However, a word of caution is that meta-analysis is based on a small number of studies, I think about 4 studies, and out of the 4 studies, 3 were conducted in Iran and Egypt. So this result really need to be replicated and verified in more diverse populations.
Okay, so you don't recommend that women now listening to this go out and buy vitamin C and vitamin E and start taking it, or What would you say to that?
I'd say if you're desperate, if you really want to take some supplements, that will probably be the best bet for now. But just be aware that if it doesn't work, then maybe it's just not for you, because it's really not been verified in all sorts of populations to date.
Yeah, okay, that's really helpful. The other thing that's kind of exploding on social media is microbiome testing, nutrigenomic testing, and often these things are very expensive, but women feel, again, they're desperate, and they're kind of sold into the idea that if you get these tests done, you will have the answers that will help you in the long run with your endometriosis. What's your view? What's the evidence-based view on whether or not these things are useful tests to be doing?
So microbiome actually has been proposed as one of the hypotheses of how endometriosis came about, simply because some studies have shown that there is evidence of microbiome imbalance in endometriosis. But given that if it actually costs a lot of money to actually get tested out, if I've got a patient standing in front of me and asking if she should go for it, I would say probably not bother, simply because healthy diets, regardless of what end you're trying to achieve, looks pretty much the same with or without the microbiome testing. It's basically what I've just said would be a plant-based diet, whole grains, fruit, vegetables, good protein, healthy fats, and limited saturated fat, trans fat, and sugars.
Absolutely. Yeah, that makes total sense. And what about the nutrigenomic testing? Is that something you would advise?
At the moment, I don't think there is enough evidence to actually justify for the cost, I think.
Great. Okay. So in summary then, so takeaway for any of our endometriosis listeners, their diet should look like a plant-based diet with lots of whole grains, legumes, and minimal meat and saturated fats and processed foods. Is that right?
That's right.
And it sounds like that is the diet that actually I would be advising for anyone who's interested in longevity, anyone that's interested in preventing cardiovascular disease and diabetes. And actually, we're all singing from the same hymn sheet in terms of that.
Exactly right.
Yeah. Okay, great. Thank you so much for coming on. I really appreciate interviewing you today.
My pleasure.
Great. Thank you. So my next guest is Professor Ford. She is the lead researcher at the Gynaecological Research Center at the University of New South Wales and the newly appointed scientific director of the new Endometriosis Research Institute, which is amazing.
Thank you. Yes, it's pretty exciting.
Congratulations.
Week.
Yeah.
Thanks so much.
What a week you're having.
Yes, it's an exciting week, and it's also pretty inspiring to be here at the Congres.
It really is.
And just be surrounded by all of these people that have devoted their careers to endometriosis research, and all the patients and advocates, and yeah, feeling very motivated at the moment.
Absolutely. I listened to your talk yesterday and I just left feeling hopeful and inspired, because it was such a beautiful vision for the future for the endometriosis care community. Will you talk a little bit about what your vision is?
Yeah, so yesterday I had the honour of giving a keynote at the Congress, and really I spent a lot of time thinking about what message I wanted to deliver. I didn't want to present lots and lots of slides of research data. I really wanted to think about how we could frame endometriosis slightly differently, and how we could perhaps be more ambitious than we currently are, and particularly how we could use some of the lessons we've learned from other diseases where there has been progress over the last 30 years, and really steal things from other diseases to improve things for people with endo. So all of the opportunities we have now with genomics and precision medicine can absolutely be applied to this disease. And I really think it's just a matter of investment and research and time, and we can absolutely improve things.
And it feels like we're getting there now with the investment side of things. Certainly before it was, women's health is so underfunded, and that's why it's so under-researched. But actually now you've got this 50 million investment, and there has been a similar investment over in the US at the second centre. So that just feels incredibly hopeful that we're finally going to get there.
I agree. I think it's been woefully unfunded for many, many years, and I think people have been dismissed, and I think researchers in this space have really struggled to compete against other diseases and more prominent things in order to get the funding, and that's been a real shame, and it's meant that there's been a little bit of lack of progress, only because of the lack of numbers of researchers and the lack of sort of scale that things can be done at. So yeah, yeah, I think at the same time we've seen much more of a global conversation about menstrual health, broadly women's health, medical misogyny, people understanding that these things are not less important, they have just been overlooked.
Absolutely.
And I think at the same time, in parallel, we've clearly seen more women medical doctors, more women researchers, more people leading labs, more women successful in business that have raised money and that want to use it for purposes that they feel will address their needs and those of those they love. So I think that combination of things and the opening up of public conversation and a little bit of rage and anger is not a bad thing.
It was needed though. It really was needed, wasn't it? Yeah,
absolutely.
And what do you feel like your goals for the Institute are as you get up and running? Yeah,
so the Institute, I mean, we've had this incredible gift from this family. The Ainsworth family are an Australian family that have been affected by endometriosis. It's very personal for them. They are philanthropists that donate to many causes, but this is one very close to heart. And so, that they are convinced, and this is what I adore about them, that science is the answer. And actually that research into the basic biology of endometriosis, understanding that it's not one disease, that we need to now stratify it, and we need to do the research to be able to clearly say there are, type A, type B, type C, type D endo. One might respond to surgery, another one absolutely might not. Another one might respond to an immunotherapy that we're giving to cancer patients at the moment. Another one might not. And actually then taking into account people's individuals' choices about fertility. Maybe they want to have kids, maybe they don't want to have kids, but let's not frame it in that manner all the time. So the Institute is really taking a lot of the lessons from precision oncology, so the individualised treatment in cancer that we now see having massive effects, and applying that to endometriosis.
Amazing. And so tell us about that, because I know that's your research interest, isn't it, ovarian cancer. So how are you applying the lessons learned there into endometriosis?
Yeah, I guess I've been in ovarian cancer research for quite a transformative period of time, where really 15 years ago everyone was receiving a very harsh chemotherapy treatment, and it was not stratified depending on who the person was or their type of cancer. And now we're actually in a period of time where almost half of ovarian cancer patients benefit from a targeted therapy called a PARP inhibitor.
Right.
And it's such a fascinating story because it's actually a drug that was developed through investment in breast cancer research. It works on patients that have a BRCA mutation, and then it was sort of retrofitted to ovarian cancer patients that share the same mutation. And as many clinicians have said to me, their waiting rooms are now full of people for the first time in their entire careers, people that are long-term survivors of ovarian cancer, which we've never seen before.
Amazing, yeah. And I know that you were working as well on early detection, because that's a massive problem with ovarian cancer, is that the majority of cases actually present at a late stage. So what are you finding there? Are we any closer to having something to use as a screening tool even?
Yes, we're definitely closer, I'm pleased to say. I think, as you've so eloquently put it, the problem is that most ovarian cancer patients are diagnosed at stage 3 or stage 4. And the early cases that we find in stage 1 or stage 2, it's usually what we call an incidental finding. So it's just sort of by accident when they're being seen for some other issue. But if we detect ovarian cancer at stage 1, the survival rate is over 90%, which is incredible. So that's what we're aiming for. And so we're in this place in molecular biology and technology now where we can actually detect tiny amounts of DNA in the bloodstream. And so many women know about this from perhaps their pregnancies. So sometimes people do something called non-invasive prenatal diagnosis when they're pregnant, and it's a way to look for genomic abnormalities in the fetus. And so it's the same idea in cancer early detection test. It's the fact that cells in our body divide and die and their DNA is released into the bloodstream.
Got it.
So many years ago we started to think, well, hang on, this technology could be used to detect tumour cells in the blood as well. And so that's what we've been pursuing for over 10 years now. But I'm very pleased to say we're extremely close to opening a clinical trial now, and we've narrowed it down to 3 biomarkers of ovarian cancer that we are confident in. And now we're trying to figure out the way to get that to people as soon as possible.
Yeah.
We still need to obviously check that it is appropriate, and we need to think very clearly and carefully about which type of people should take this test. But the fact that we've got there is very exciting.
Yeah, and that's important, isn't it? For any screening test, it's about defining the population. I imagine you're thinking of this being used in high-risk patients rather than the whole population.
Yeah, you're spot on. Yeah, absolutely. So, I mean, ovarian cancer, as devastating as it is as a disease, is still a rare cancer if we look at the entire population. So it's unlikely to be appropriate for everyone to have this screening test because the maths just doesn't add up in the way. But absolutely for people that have an elevated risk of ovarian cancer, either because of a family history, a genomic aberration, or dare I say, perhaps some people with endometriosis, this will be, I think, incredibly useful in understanding and also in patients' sort of triage, as we would call it. So when people come in with vague symptoms that may or may not be ovarian cancer, we're hoping that this blood test will really help fast track their treatment if that is the case, but also rule it out if it is not the case.
And I just love the fact that research is moving away from just seeing endometriosis as just a reproductive disease and actually looking at it as a whole person disease, as it really is. You know, this morning we talked to Dr Siew Lim about the increased risk of cardiovascular disease with endometriosis patients. Now we're talking about the increased risk of ovarian cancer. And it's so amazing that these things are all being talked about now. So what is that link between ovarian cancer and endometriosis?
Yeah, look, I don't know the answer, to be really honest. I think that's the shame. We don't know. But so I've worked in cancer biology for many, many years, and my interest in it is how cells change their shape, how they invade, how they grow, how do they actually spread throughout the body, this process we call metastasis. And when I started to become interested in endometriosis, I was surprised that exactly the same sort of behaviours in cells happen in endometriosis. And I still, to be honest, can't quite fathom why it's not almost considered a malignancy, because it shares many, many of the features of cancer. And I don't say that to alarm people at all, but just in the way that the cells grow and the way they invade, it's very, very reminiscent of cancer. I think it's important to note that most people with endometriosis do not go on to develop a gynecological cancer.
Okay.
But a small number do, and we need to figure out how to identify who they are.
Okay. And do we know anything about which subset of endometriosis patients that is? Is it people with endometriomas? Is it people with highly active disease, deep infiltrating versus superficial? Do we know anything?
I think we don't know definitively yet. We've got some hints perhaps, but the numbers of patients in those studies are not large enough to be really, really clear. So I wouldn't want people to get the wrong idea about things. I also think potentially our labelling and subtyping of endometriosis at the moment is not entirely appropriate. So it's probably subgroups within each of those current labels that may have an increased risk. And also you have to think that endometriosis often lasts for tens of years and changes. Each individual will undertake different treatments. They may have one surgery, they may have multiple surgeries. We also know from oncology that surgery itself and the repairing of the wound has an impact on future biology. So I think it will be quite individualised, but that's why, particularly with this new research institute that we've launched, that's going to be a big focus. Actually, international data collection, tracking people, collecting lots of clinical information regarding symptoms, regarding what sort of intervention did you have, how are you responding, what are your symptoms like? Hey, does someone in your family also have endometriosis? Oh, your mother, did she ever talk about having painful periods? Just really trying to build that entire picture, both from the patient side, but also the medical side. And then I think we'll be able to learn a lot more quickly. Absolutely.
And you talked about repurposing cancer drugs. Do you see that any other drugs in other fields being repurposed for endometriosis? Or
potentially. I mean, I think it could come from anywhere. So, I mean, the drugs are working on different pathways and we are still sort of figuring out what the key pathways that drive endometriosis growth of the lesions, but also what's causing the pain, what's causing the inflammation. I think, again, it's not going to be one drug for endometriosis. It will be a range of them, but hopefully we get to a point where we can identify the subtype and what the actual, like what the part of endometriosis that's causing difficulty in a patient's life. So is it all about the pain? Because we know that pain doesn't correlate with the amount of what we would call in oncology disease spread or disease burden. You can have a whole bunch of lesions and have no pain whatsoever, or you can have one lesion that is removed and your pain continues. So I think trying to figure out what's appropriate for each person is where we need to have the vision. It's
so
the future.
Personalised care is the future.
So it's not necessarily, most oncology drugs work by killing the cell, right? So destroying the cell. And so that's not going to work if your lesion, your endometriosis lesion, isn't actually, let's say, the major source of your problems. So yeah, it could come from anywhere. It could be a whole range of things.
Well, I am super excited and hopeful for the future of the Institute. Can we just end by talking about your Ovaries Talk About Them campaign? Tell us about that.
Sure. So the Ovaries Talk About Them campaign is a little bit unusual, and it came through
very glossy.
It is very glossy. Yes, I've had to up my fashion game.
No, it's very cool. It's the Goop effect.
Yeah.
You know, if you can make something look like Gwyneth Paltrow, we might get some money.
More attention. That's right. So an Australian fashion label called Camilla and Mark. It's actually named after the brother and sister, Camilla Freeman Topper and Mark Freeman, that run the brand. Their mother sadly died from ovarian cancer many years ago when they were teenagers. And as they entered around their sort of 40s, I think they became very motivated when their own children were a similar age to their age when their mother had passed away. And so they came to visit my lab. They asked for a lab tour and we, welcomed them to the laboratory. We talked to them a little bit about research. And I think they were very motivated already to do something regarding to use their fashion label to raise awareness. And so, yeah, we've partnered with them for about 5 years now. We have an annual campaign where Camilla designs a great t-shirt or a tote or a cap so people can purchase things which they walk around and wear and start a conversation, so people don't feel shame or stigma around talking about ovaries. But it's direct fundraising, so all the money goes directly to my laboratory. It doesn't get filtered through university grants offices or through charity costs. It comes 100% to the lab, and that pays the salaries of the researchers. So it's been
amazing.
Been a really nice experience.
Yeah, that collaboration and that innovation of thinking about new ways to get funding and get awareness out there, I think is genius. It's absolutely brilliant.
And I think as a scientist, it's been fascinating to work with business people because, again, they have pushed us really hard about, what we need to get this to a clinically available test, and also their knowledge of communications, of branding, of how to get a message through, their cut through in social media and other things, I think has raised the profile of ovarian cancer globally and certainly to a different audience that may never have heard of it before. So if they see their favourite influencer or celebrity or actor talking about ovarian cancer, then they might think about it, or they might have a conversation with their parent, or they might go, oh, okay, that might prompt me to go and see my healthcare provider. And I think those stories that I have heard every year after each campaign has been almost more impactful than the research itself. So that ripple effect of just starting a conversation is a wonderful side effect.
Amazing. We need to just keep doing it with all of women's health. Really,
yes, I agree.
Yeah, great. Well, thank you so much for coming in to talk to us. It's been a brilliant conversation and we look forward to seeing what the Institute does in the future.
Thank you so much.
Next up, we have Professor Holly Harris from the Fred Hutchinson Center in the US, and she has got a special interest in research around lifestyle and endometriosis. So thank you for joining us today.
Yeah, I'm happy to be here.
Thank you. So we heard your amazing talk this morning about your randomised controlled trial looking at alternative healthy eating in endometriosis and the outcome. So can you tell us about that? Because I think that was pretty groundbreaking in terms of the fact that we've now got some evidence for dietary interventions in endometriosis.
Yeah, thank you. I was really excited to be able to finally show people the results of the trial. So what we did was we took over 100 women with endometriosis and we randomized them to either eating their usual diet. So it felt a little bit bad for that group because they needed to just, for science, be consistent with what they were doing. And then the other group, we asked to eat a diet called the Alternative Healthy Eating Index, which really has 11 components, but generally I describe it as a healthy diet.
Right.
Not a lot of red meat or processed foods, eat your fruits and vegetables, and, get omega-3 fatty acids through foods. And what we found was after following the participants for 12 weeks, those who were randomized to the intervention, so were taught by a dietitian how to eat the healthy diet, their acyclic pelvic pain, so the pain that happened not around their period, was reduced. Much more than the group who was asked to stay with their regular diet.
Amazing, amazing. And it's one of the first trials we have in this, because I think one of the problems with, if you look at social media, it's awash with endometriosis diets. They often tend to be quite restrictive and actually cause quite a lot of confusion, and women end up feeling kind of a bit desperate because they've been asked to cut out all sorts of things. And so it's so great to finally have some evidence which shows actually you don't need to cut out everything. So again, tell us exactly what the diet was talking about, because it wasn't about cutting out dairy and cutting out gluten. It was actually about just a healthy diet, as you say.
Yeah, exactly. So the things you're encouraged to eat are fruits and vegetables, whole grains, if you're interested in eating fatty fish. We actually did tailor it though for people who were vegetarian, and then we would replace maybe the fish with more nuts or things like that. So, and then it said to eat less red meat, less things with sodium, but we also had desserts as part of our menu. So made this healthy brownie that was made out of bananas and different things. So we try to make it we're humans and we want to eat good food too.
Yeah.
And so we didn't ask people to cut out dairy. We didn't ask them to cut out gluten. And we did see that people's pain was reduced even without cutting out those things. So
yeah, it's amazing. Did you look at inflammatory markers at all? Did you look at them before the diet and then afterwards, and kind of almost prove that it was the inflammation that was at play?
So we collected blood samples, and we are going to do that. And we actually had done a pilot though earlier of this diet in 15 people, not with endometriosis, but people of reproductive age. And we did see some inflammatory markers fall over the course of 12 weeks on it. So we think we'll see a similar thing in people with endometriosis, but we've sent off the bloods to be analyzed. So we hope that that'll give us an idea of the mechanisms, behind why it's working. And do you feel, so obviously that's being used to treat symptoms, do you feel that we're going to get to a place where we can start almost prescribing a diet to help prevent endometriosis? I mean, I think I certainly see a lot of patients who might have endometriosis themselves, but are getting to that stage where they have teen girls and they're saying, I want to do anything I can to stop her going through what I've gone through. What can I do? Yeah, it's such a great question, and I actually do some adolescent diet work, so this really fits well with all of my research. So I work in large cohorts, and those are groups of people we follow for a long time. And what we've seen, actually the way we identified the diet we picked in the trial, was that eating this dietary pattern reduces even being diagnosed with endometriosis.
Wow. And
we thought that was probably still a pain mechanism, because you're not coming to clinical attention if you don't have pain.
Yes.
So I think that this alternative healthy eating index diet, if eaten in adolescence, we actually saw recently in a study we published in the last month that eating this diet shifted the age at your first period to slightly later, which is a risk factor for endometriosis. So I do think that encouraging, teenagers to eat as healthy as they can. I have a 13-year-old girl though.
Yep, so do I.
I also understand we want to also develop healthy attitudes around food and not problematic attitudes around food. So we talk about fueling our body like it's a car.
Yes.
Put the good fuel in, have the treats, but in moderation. So I think that's really the best message.
Exactly, because we don't want to take one problem and then create another. And I think at this age, as you say, around teenage girls, labelling food as good, bad, you definitely don't want to eat that, could eventually introduce issues with food, a relationship with food as well. So we do have to be balanced about it. But that's really interesting that you're seeing the prevention side of things as well. I do really feel like from the endometriosis community that diet and lifestyle changes is something they want, and we keep saying to them, well, it's not evidence-based, it's not evidence-based, and they're doing it on their own. So that's where they are going to social media and saying, well, this is the way I want to manage my endometriosis, so I'm going to look for solutions myself. So that's why I said it's just absolutely brilliant that we've now got some evidence actually to do it in a non-restrictive and safe way, healthy way. That's brilliant. I know that you also have done research into trauma and its impact on endometriosis. Can you tell me a little bit more about that?
Yes, so it's a couple of years ago now, but we published a study looking at physical and sexual abuse in childhood, adolescence, and early adulthood and risk of endometriosis, and saw that basically most forms of trauma and with more trauma, you would have higher risk of having endometriosis in adulthood. So I think the important thing about that study, though, because it hit a lot of patients in a hard way, and that we're not trying to create stigma. It doesn't mean that everybody with endometriosis was abused. That's really important. We think the association is related to a pain pathway, potentially, but it's not because the pain is in your head. It's really a full embodiment of what you've been through. And so I think that's an important part that we like to think about in terms of that study. I mean, we've seen a lot of abuse associations between sexual and physical abuse and fibroids and different reproductive outcomes. So I think it just points to the connection between a pain pathway and later life.
Yeah. And are you able to extrapolate any of that data in terms of trauma and stress and its impact on endometriosis? Because that's, I think, is such a big trigger for people as well, is stress. And what that makes me think of is that there is clearly a mind-body connection, and you've seen it in patients with physical and sexual abuse, but actually on a spectrum, even if a patient is experiencing a high level of stress, not because of that, it might impact their endometriosis.
Yeah, I think there's more and more evidence that stress is playing a role. What role, we don't exactly know. We tried to look at whether social support would buffer some of these associations with abuse, and actually didn't find that to be the case in this study, which does speak to the stress, pathway. But I think we need a lot more research to really understand the role of stress.
Yeah.
Even bringing it back to our diet trial, if someone's under a lot of stress, how can they change their diet? And so this is something I'm interested in, in the next study we do, is how do we provide support to lower stress?
Yeah.
Because I think that's really critical to, people living healthier lives and reducing their pain.
Yeah. I know that you also have an area of interest in cancer. Tell us about that, and tell us about any links, if there are, between cancer risk and endometriosis.
So in the cancer research I primarily focus on ovarian cancer, which is the cancer that's most strongly associated with endometriosis. So endometriosis is associated with 2 to 3 specific types of ovarian cancer, endometrioid and clear cell especially. But the thing that we're really missing right now, the piece we're missing, is we don't know who with endometriosis will go on to develop ovarian cancer. And so that's something that my group has been working on, trying to understand, is there a risk factor profile among people with endometriosis? Because ovarian cancer is still very rare. So it doesn't need to be something that people are worried about excessively, but if your risk goes from 1% to 3 or 4% over your lifetime, ovarian cancer is not a good cancer to get.
Absolutely.
So we're really trying to understand more about what puts someone at a higher risk.
Yeah.
And I think the other, complicated thing is your ovaries are important. So the question of whether to keep them when you're at higher risk, and then people with endometriosis have a higher risk of cardiovascular disease.
Yes.
And so if you take your ovaries out because of cancer risk, you may increase your risk of other things. So we really need to think of a whole broad spectrum of risk of a variety of things across someone's life.
Yes. So for anyone listening who's got endometriosis, you're saying that there is a slight increased risk of certain types of cancers, but that risk is low. And it's certainly not something to be overly concerned about. Be aware, but not be overly concerned that, this is going to happen to you, definitely. And certainly what you're saying, I think, is that there are certain subsets of people with endometriosis that are more at risk, and we're not sure who those people are.
Yes,
Yes,
exactly. And
got it.
I know people are working very hard on trying to understand that.
Yes.
So.
And at the moment, I mean, I think if you did have a woman with endometriosis who was worried about her risk, is there anything that she can do in terms of screening? Because there aren't really any screening programs, are there? So even if she were, what would she do with that?
Yeah, that's a great question, because on a population level, we don't have a good screening test for ovarian cancer. So I think it's a conversation between her and her, gynecologist, who hopefully is like listening and helping, look at, their family history and a variety of factors. To help determine like what's the right, is there a right screening strategy, for this person.
Yeah. So going back to your study, do you feel now that we can safely say that we can prescribe an endometriosis diet to our patients? This is what you should be eating. Do you think we're there yet?
No, I mean, as a scientist, you always want to say, there needs to be more research.
Yes,
but
yes.
I do think the Alternative Healthy Eating Index has been shown to reduce risk of a number of chronic diseases.
Exactly.
So there is nothing, I don't see any drawbacks to advising people to eat this way, because it's got a lot of benefits. And that way, if it doesn't help your endometriosis, I don't want people to feel guilty or to think that they haven't done it well enough. So I think we can definitely say it's something that people could definitely try, and there's not a lot of harms to doing it. And hopefully, we can do some more studies to really understand, are there certain parts of the diet? Is it really just the whole, the whole diet together? So
quite a lot of people will decide to cut out gluten or dairy, and some people do get a benefit from that. Why do you think that is? Why do you think, even in the absence of celiac disease or in the absence of a true allergy, why is it that they're getting some benefit from it?
Yeah, that's such a great question. And, I think probably a nutritionist would do better than me on answering this. But I will say, certainly with gluten, gluten itself is related to some of the FODMAP components. And I think there is good evidence that, eating a low FODMAP diet can improve people with endometriosis, that their symptoms that mirror IBS. So it could be it's not the gluten itself, but you still remove something that's problematic. And the dairy is an interesting question, because we've actually seen in some of our work that dairy lowers risk.
I saw that today, yeah.
And we've checked whether that's reverse causation, but I think in general, people with endometriosis often report a lot of GI issues. And so if your GI is exacerbated by dairy, it's not necessarily that it's your endometriosis per se, but if you're slightly dairy intolerant, then removing it, it could help. So I think that people should just, have a balance, and I think that's why meeting with a dietitian is really great, because they can help walk people through their individual,
Absolutely.
triggers.
Thank you. So we've talked about your research in diet and endometriosis. We've talked about your research in abuse and trauma. What is next for your research in terms of lifestyle and endometriosis? What are you looking at next?
Yeah, well, actually, so my next project, taking a little bit of a step back, is working with a large cohort called the Black Women's Health Study, and looking at whether risk factors for endometriosis are similar in Black women than they are in white women, because at least in the US, Black women have not been studied in the same regard with endometriosis. So we feel like we need to change that.
Absolutely. How amazing that you're going to be doing that.
Yeah, so that's our next, study, is to really just look, are the risk factors looking the same in this really wonderful cohort? And so I think from that, then we'll be able to, just have a better picture.
Yeah, and be able to provide even more personalised care, and actually say to people, okay, actually, your daughter is at risk because of X, Y, and Z, and this person is at risk because of that. I think that's incredibly important in giving that women that information.
Yeah, so that's our
really
next
helpful.
project we're working on.
Yeah.
That I'm very excited. I'm really excited to be able to do that one.
That's going to be great. How many people have you recruited so far?
Well, it's a study that's been going on since 1995. So they have over 80,000.
Oh, wow.
So it was designed to look at, a variety of factors.
Yes.
So, and I think, they'll have over a couple thousand people with endometriosis in that study.
Right. Wow, so you're well on your way.
So yeah, we need to
just look at the data.
Analysis.
Yeah.
So
brilliant. Well, I'm very much looking forward to seeing the results of those. And thank you very much for your presentation today. It was really, really interesting, and I'm really pleased that we finally got the evidence base starting to come in for that. So thank you very much. Thank you for talking to us as well.
Yeah, it was great to be here.
Appreciate it. Thank you. All right. Okay, so my next guest is Dr. Lydia Coxon. Thank you so much for joining us. Lydia is a researcher at the Oxford University with a special interest in pain mechanisms in women with chronic pelvic pain, especially endometriosis. So we're going to talk about your amazing lecture this morning about endo flares, because I'm sure there are so many women at home who'd like to know more about it. So tell us, what is an endo flare?
So I think it's kind of tricky as a researcher for me to give a label to something that people are using, right? I've adopted it because that's the term that patients are using. So what we use in the survey that we do is the definition of symptoms that are much worse than usual.
Right.
So it's really quite broad. It's meant to encompass anything that you would consider a flare.
Okay.
I think moving forward, we want to do a little bit more to try and really pick out what this means to people.
Yeah.
But right now it's really important for it to be loose because I want people to use it how they use it.
Yeah. So it's basically a term which we've kind of adopted from on the medical side, but taken from what patients are actually using to describe their own symptoms, right?
Yeah, exactly.
So that could be, a flare could be feeling more tired or being in more pain or whatever their usual symptoms are, but just worsened.
Yeah.
Is that what?
Yeah, exactly. So much worse. So your pain might be much worse. You might need to wee a lot more. You might need to have much more urgency going to the toilet. So anything like that makes you feel like it might be a flare.
Okay. Yeah. And how often are we seeing women with endometriosis complain of having these types of flares?
So in the survey that we've done, it's massively varied. Mm-hmm. So some people have it 3 times in 10 years.
Right.
Some people have it 10 times a day.
Goodness.
And there's everything in between. Mm-hmm. So there's lots of variation, and we look at different length flares, so short flares, medium flares, length flares, and long flares.
Okay.
So whether they're less than an hour or more than a day.
And what are you seeing there with the different lengths?
There's a real variety. The most prevalent in this study is the long flares. So I think 85% off the top of my head reported the experience of these long flares, these day-long flares. But these can be up to 25 days in length. So
goodness.
They're really long-lasting. I think I was sort of expecting these flares to be almost like an electric shock, like there and gone. But that's definitely not what we're seeing. These fluctuations in symptoms can last for a really long time.
Such a long time. And I imagine if they're lasting for that long, they have a massive impact on quality of life. I know that you looked at quality of life symptoms as well, didn't you?
Yeah, exactly. And we did something, we measured a sort of proxy time in flare. So we used the average length of their flares and how frequently, on average, they reported the flares, and used that to calculate a sort of time per month they spend in flare. When we looked at that, it was 96 hours a month they were spent in these flares. Goodness. So that's 4 days a month, which is a huge proportion. And when we looked at that was correlated with their quality of life. So the longer the time they spent in flares, the lower the quality of life, which I think is something that people can probably would guess, but it's really important that we have the evidence to show
documented.
How important these flares are.
Absolutely. I mean, you can imagine women having flares in that way would find it so difficult to work, so difficult to kind of have a social life. So you can imagine how it impacts quality of life, definitely.
Yeah.
And I imagine what you're going to say is that from the survey you found that some women's flares, length, time, the symptoms they were having were completely different to other people. So there was a lot of variation, was there?
Yeah, huge variation. So there's variation in terms of the length, the frequency, and also the things that trigger the flares. So we asked what things have you identified that trigger the flares? And about half the people could identify triggers. And what triggered them was really varied between people and between different length flares as well. So there's huge variation in this, which means it's really exciting from a research perspective, but also means there's a lot more to do to try and unpick what's driving that variability.
Yeah. And also shows that endometriosis isn't just one thing.
Absolutely.
It's something, that's kind of personal to each person that has it, and it can be very different from person to person. What were the types of triggers that women were talking about?
So there was a few that were reported a lot. So the stress was something we found in previous research, and in this, the people reporting as a trigger for flares of all lengths. Menstrual cycle was a really common trigger for long flares. which I think fits with what we sort of would expect for endometriosis. But things like prolonged standing was also a really common trigger.
Interesting.
And bumpy or jarring movements, that was also something. So there's some that are sort of what we'd expect, but there's also some that seem to be slightly different and not necessarily what we'd expect. So it's good to look at that in more. And it's what we were finding is that there's flares for the short, medium and long were slightly different, with which was the most common trigger for them. And we think that these different triggers might be relating to different things driving these flares. So if we can try and unpick that a little bit more, it'd be really useful to try and work out what mechanisms are underlying these flares.
The pain, exactly.
Yeah.
And the one part of your lecture which made me feel really sad was the idea that these women are having these flares, but the vast majority don't feel like they want to contact their healthcare provider. And yes, some of them, it was for a good reason. It was because they felt like they could cope, that they had the tools. But for a lot of them, it was because they didn't feel that they were going to get the help. Can you talk about some of the reasons within that people talked about in the survey?
Yeah, so when we looked at it, we sort of grouped them based on a theme. So one of the themes was that I'm confident coping myself, it's going to pass. I have all the skills to deal with this, I'm happy, I don't need extra support. But like you said, there were some that were relating to not being able to or accessing care. And one of those was the sort of idea that what can they do? Which I think is something that's really important, and I think something that we need to look at in the research, because at the minute we don't know what prevents or treats flares as they occur. We know what's used in clinical practice, but we don't know what is effective in endometriosis flares. So I think in that sense they're right, we don't know what they can do, but it's really sad that that's the feeling that they have.
Yeah, it is really sad.
Another one was around sort of broken healthcare system, is sort of what I've sort of termed it, but this idea that there's really long waiting lists, it's really difficult to reach a healthcare provider, and so that's one of the barriers there. There was perceived dismissal and gaslighting, which I know we hear a lot about in endometriosis, but this, I've been before and they didn't listen, so why would they listen now? They never believe me, why would I bother going? Because I just have to explain to them what it is and they don't know what it is, and they don't believe that I'm in pain. They think I'm just seeking pills and things like that. So I think that's really, and I think one of the things with that is it's really important to acknowledge that even as we move forward, and I think clinical practitioners are getting more and more aware, and hopefully this dismissal is happening less and less.
Absolutely.
That if it's happened in the past, that's going to mean that they're not going to access care in the future. So they're not going to see that things have changed. So that's something that we need to work at breaking down.
Yeah, definitely. I mean, I think for me as a healthcare practitioner, as I said, it just made me feel sad, because we do want those women to come in. Yes, we don't fully understand endo flares, but I know you've done some research in chronic pelvic pain mechanisms and understanding. I think I looked at your TRIP study and looking at the various ways that women with endometriosis kind of sense pain, and how that's different from the general population. So there are things that we kind of know about it. Can you tell us a little bit about that, and about how women with endometriosis experience pain that's different from other populations?
Yeah, so I think when we talk about chronic pain, there are sort of three main mechanisms that everything sort of falls into. So you have your classic, what we call nociceptive. So that is, you stub your toe, there's something in the periphery that activates something, that signal travels to the brain, your brain perceives it as pain. That is the classic one that you'd think of most of the time. That's what we historically thought of endometriosis consisting of. It's also the type that generally works best with painkillers and things like that. They seem to be effective in it. There's a lot of inflammation, we can target that and things like that. So that's sort of what we've always assumed. The other two types is, one's neuropathic, so that's pain due to damage to the nerves themselves. So it's not that there's something in the tissues in the periphery so causing it, but the nerves themselves are damaged, and that's what's causing your brain to perceive pain.
And is it the endometriosis which has damaged them?
At the minute, we don't really know. So we know in people with endometriosis that there is this sort of neuropathic-like pain in these people, so we can use screening tools and things like that, and we see some of the hallmarks of neuropathic pain. So one of those is sort of sensory loss, so a lot of loss of function in the area. That's sort of a hallmark of it. But at the minute, it's still very much an area of increased research. So there's ways we think it could happen. So endometriosis lesions themselves are innervated by new nerves. Obviously, they're bathed in a sort of inflammatory soup. They could be squished by the lesions. Then if people have surgery, any surgery, there's a risk of neuropathic pain because you're cutting through. And then you're cutting out the lesions and these new nerves there as well. So there's a few mechanisms that could cause this neuropathic pain.
Right.
But we don't know completely how it works yet.
Okay.
And the third mechanism is quite a new term that's called nociplastic pain.
Right.
And one of the conditions that's sort of a hallmark of this is fibromyalgia. So it's sort of often characterized by widespread pain. So this affects the whole body. You get this sort of brain fog. You might get more general sensitivity to light and sound and things like that as well. So that's the third type, that there's also growing evidence that exists in endometriosis. So
because there is a correlation between fibromyalgia and endometriosis, isn't there?
Yeah, exactly. And a lot of these comorbidities, if we think that some of this overlap might be because of these nociplastic mechanisms that make you more vulnerable to multiple chronic pain conditions. So where we are at the minute is trying to work out in one person with endometriosis which combination of these mechanisms might be driving the pain. And that's what we're trying to unpick a bit more now in research.
Okay. And what is your next area of research in endometriosis? Where do you see it going next?
All sorts.
All sorts. Go on.
So I think one of the things that we need to get better at doing is trying to group people. So based on these mechanisms, based on things like that, grouping people based on those, rather than taking this big blob of people who have endometriosis-associated pain and trying X.
On all of them.
On all of them. And then, X doesn't work. But maybe X would work in this group of them.
Yeah.
And we need to get better at picking out what treatments or combinations of treatments and strategies will work best for which groups. Because I do think there's a lot that we could do better with this, and this sort of shift towards a more personalised treatment is going to be, I think, where the answer is. I don't think we're going to find a magic pill that is going to cure endometriosis-associated pain. I think there might be a magic something for everyone, but that's going to be very different from person A, B and C. And trying to work out how we do that, I think, is where this work is really going forward. Yeah.
And you've obviously talked about nerves and nociception, and then this new nocioplasticity. But what about the other factors which influence pain? Kind of the social factors, the psychological factors. So it's, when you talk about, actually, it's not just about treating endometriosis pain as a whole, it's very personalised. Is it because those factors are very different in each patient?
Yeah, exactly. There's so many things that influence pain, and we know from in acute pain settings, so even if we play sad music to you, you feel things more painfully.
Amazing.
It's incredible.
Yeah.
So there's a whole barrage of things that we know can influence how you feel pain and how much impact that pain has on your life as well. So it's not necessarily just the intensity of the pain, it's the added burden that that's having on the rest of your life. And like you say, there's the social aspects, how well supported you feel is going to have a massive impact on how your life is because of this. And things like that. So there's a huge lot of stuff in the psychology and the societal sort of thing that can be really, really important in unpicking this and getting to a better solution in the end.
By saying that, by acknowledging that, we're not saying that the pain is all in their heads, that it's a psychological problem. It is absolutely a real physical problem, as you described. We're just saying that other factors can have a impact on it.
I mean, I guess I'd flip it the other way.
Go on,
I would say pain is all in your head, but that doesn't mean you're making it up.
Great.
So I think your brain is the organ where pain exists. Pain doesn't exist anywhere else. It's your brain that pieces it all together and tells you that it's pain. But that doesn't mean that it's not real, right? There's so many things we experience in our heads. That's how we go through life. It's all in our brain. But that doesn't mean it's made up. And it doesn't also mean that if we can't find something that you're making up, there's none of that. If you're experiencing pain, you're experiencing pain. That there's no more to it. And all the tests that we do, it's always fundamentally, do you feel pain? Is this painful? Yeah. Because that is the outcome.
Yeah, exactly. Okay, amazing. Thank you so much, Dr. Coxon. That was brilliant.
So next I'm joined by Professor Mikocka-Walus, a psychologist specialising in behavioural interventions for patients with chronic pelvic pain, especially endometriosis. Hi, thank you so much for joining me today.
My pleasure.
Thank you for having me.
Tell me a little bit about what you do and what your research interests are.
Look, for the last 20 years, I've been doing a variety of research in the context of chronic pelvic pain. It started with gastroenterology, and the last 20 years have also seen the development of a discipline called psychogastroenterology or gastropsychology, depending how you prefer. And sort of this is a discipline in which you would use behavioural psychological interventions to support people living with gastro conditions. At some point, this led me to research on endometriosis as well, because there's quite a big overlap between symptoms of irritable bowel syndrome and endometriosis, and obviously pelvic pain is common for both. So that's really what I do. I typically develop or co-develop with participants psychological interventions that are tailored and personalized to people with different chronic conditions. Endometriosis is my current main interest.
Okay. So it sounds amazing, and I definitely want to hear more. I mean, I think for any endometriosis sufferers listening, one of the issues might be that they have been dismissed and told that their pain is in their head and that it's not real for so long that potentially us talking about psychological therapies in relation to chronic pelvic pain might feel a little bit concerning to them, that we're saying that the pain is all in their heads when we're not. So can you explain how psychological therapies actually relate to endometriosis, which is very much a physical condition?
Yes. Look, I think there's quite a lot of examples. So endometriosis doesn't have as much research as sort of gastroenterology, where I started. So that's why I like to come back there. So in a way, the same discussion occurred when we first introduced psychologists to clinics for Crohn's disease or ulcerative colitis. And people would tell you, well, I'm not mad. Why do I need you? And what we've learned since is that there are certain physiological things happening with the body, that the inflammation that you live with, which is very common for endometriosis as well, it's an inflammatory condition, that if you have inflammation somewhere in your body for a very long time, this inflammation, or information about inflammation, is sent to your brain, and the brain changes, so it modifies its response to the world in some sense. So what it can do is it can lose the sensitivity to positive emotions. Right. So you're the same person, you go around, but you see it as a sort of a more grayer world. And we know from psychological therapies that we could, through targeting the brain, we could change things for the body. And we do it through breathing, but we also do it through thought work. So cognitive behavioral therapy, where we modify how people think about different issues. So what I like to sort of say is I work in health psychology rather than sort of mental illness as the main presentation. I work with people with chronic illnesses. They come to me because they would struggle with adjustment. They don't necessarily come to me because they said, I'm very anxious or I have schizophrenia. This is not necessarily what I do. I typically help people adjust, and I could do it through cognitive behavioral therapy, through hypnotherapy, for example, if they suffer from chronic pelvic pain. And we know there's a lot of physiological explanation for why these therapies actually do work. And I would work with people who come with pain, for example, and they say, look, I've tried this, I don't want more codeine, or the codeine actually makes me constipated. Yeah. So it's not a solution for me. So sometimes I think we are the last resort, but people could be positively surprised that like somebody like a health psychologist doesn't necessarily work with mental illness. Right. We work with other resources, with other professionals, and we talk in the multidisciplinary way about how to help a person. But also, look, there is a huge value in breathing and teaching people how to breathe, because the vagus nerve, which is responsible for a lot of different problems within the body, is something that could be settled through breathing. So even if you sort of take away CBT or more sort of involved therapies, and you teach people to either meditate, do mindfulness, or just breathe, I don't know how psychological it is, but that's what I do a lot of the time. So you could argue this is almost like physio, but I just teach people how to breathe and what thoughts could accompany this. So it could be like that. It doesn't have to really go into your childhood, or things like that. So I think, look, we are helping people with whatever they bring, and sometimes people have multiple comorbidities. They come, they say, I have pain, but I also have a troubled marriage and I have this and this, and I'll try to see what I can help with this. Yeah. So one could be, you know, teaching people to communicate in a more assertive way, just so that, you know, they don't fight with their partner as much. Some of it will be about thoughts that, you know, particularly in sort of couples that have been together for a long time, there are certain, you know, you had hot thoughts that, oh, he always does that or she always does that. So breaking some of this. So a lot of it is working with this kind of things, so thoughts, but also physiology, which could be regulated by how you think and how you breathe.
Yeah, and that's really just about bringing in the biopsychosocial model, isn't it? Because there are, yes, endometriosis is a physical condition, but people experience pain in different ways because of all the other factors. So actually, you're talking about working and trying to deal with all the other factors as well as the physical.
Absolutely, and I think giving people strategies. I'm a person living with endometriosis, and when the pain catches me, for example, during the night, I'm sort of half asleep, but I have to walk because, say it's rectal pain that is really, really strong. I know that for breathing and certain types of sort of stretch, I can help it probably more quickly than if I went and took painkillers, because they need some time to work. Yeah. Whereas I'm already in bed, this will be sort of going somewhere looking for it. So some strategies, if you have them on hand, in terms of breathe or stretch or do things, and they can come from a psychologist, they could come from a physiotherapist, could be really useful. Also in situations where you don't have easy access to medication, if that's the thing that works for you, that's fine. But for some of us, it's not great, or we just, you know, at a conference like we are here today, and I don't have a painkiller. But I always have, you know, sort of my brain, and I have the techniques that I use to help myself.
Okay, so if that person you describe who wakes up in the middle of the night in pain, you're really wanting them to think about it in twofold. So you're wanting them to think about it from what their mind and what they're telling themselves about the pain, but also about some physical ways to try and induce relaxation in the body. Is that right?
Absolutely, and also empowerment, that because there's a lot of hopelessness at 3 a.m. when you wake up and you think, oh, yet again, you know, and we know it will take 2 hours, you know, if I don't do, and so some of it is anger, some of it is anxiety. Will it actually end? It ended last time, but will it? So there's a lot of thoughts here. I've trained myself to not go there with the thoughts, but more focus on acceptance. Okay, this comes. I do have strategies to do something with it. The pain, yes, is unbearable, but if I keep telling myself in my mind, it's horrible, it's horrible, it's horrible, I'm not helping it. Okay. So there are techniques. Some of it, you know, you could distract yourself. There are some hypnotherapy strategies or guided imagery where you can start sort of breathing and imagining yourself in a sort of a different place. Some of them are very direct when you focus on pain with this imagining and how you, like, for example, if you imagine pain as a color red, for example, you could do some techniques breathing and thinking of lightening the color. It's been shown to reduce the pain itself through this imagination and through thinking of changing the color. It's fascinating actually that you think about red, and then when you go to pink or lighter sort of red, the pain reduces. So there's quite a lot of techniques like that when I was trained, and I was never trained as a clinical psychologist, health was what interested me. I found fascinating because is it mental health, what I do? And I don't know how to call it, you know, but a lot of it is just about behavior and how can we modify, or what strategies we could give to people to say, okay, well, I can't get help from outside. And we heard in the presentations here that people go to doctors and doctors sometimes struggle offering you something beyond Panadol, for example, or you may not want to have the medication. I want people to have a toolkit. Yes. And that when they wake up at 3 a.m. with this horrible, horrible pain, yes, they may have a medication on the list, but if they are, say, on the plane, then, or they may not have, I don't know, there are situations where you are caught unprepared, that there is a technique, to at least reduce it a bit.
Absolutely. So this is not about telling women you shouldn't go and get help, that there isn't surgical help that you might need, that this is not about not getting a diagnosis.
No, it's an add-on.
It's an add-on, exactly.
It's absolutely an add-on. And look, I also think about it. We wait for surgeries for a very long time. We also may need them more than once. I had 2 surgeries, so it's not that one surgery will always fix everything for you. Hopefully it will for at least, 10, 15 years. But for some of us, it doesn't. And because we're waiting for it, why would we wait in pain if we can do something for it? So I'm all for surgery. It's just, as a patient, I need to survive sometimes 2 years or 3 years, so I need to not go mad with the symptoms.
The whole woman.
Absolutely. So if I can do something with my diet, because I have a lot of bloating as a result of what happens inside, if I need to do physio, pelvic physio, or if I need to get some techniques to breathe or relax the muscles here, if I do yoga, for example, and a lot of the research that I do, develops this strategies, like, for example, yoga for endo or physio for endo, and they do recognize, that there's practice around this area, how you exercise or stretch or breathe, that actually improves functioning of the pelvic area. So it's very focused. So it's not your average, I would say, you go to any psychologist or to any physio. Not everyone would necessarily know. I think it's important to look for someone who understands pelvic pain, and can support people with a particular problem. I've heard from many patients that going to a psychologist or a physio actually was a bad experience, or it was sort of useless. And I can sympathize. So some organizations I work with, for example, Crohn's and Colitis of Australia, they list people who have been trained in helping, and they are dietitians or psychologists who actually understand the difference between inflammatory bowel disease and irritable bowel syndrome. They are treated differently. A lot of people confuse this thing. So I think we need a circle of, there needs to be some kind of recognition that here is your psychologist or your physio who knows about endo.
Dedicated practitioners, yes. So tell us more about psychogastroenterology, because you talked about the overlap between irritable bowel and endometriosis, and there are a lot of women with endometriosis who do have bowel symptoms. So talk to us a little bit about that.
So psychogastroenterology, probably, I'm just trying to think where it started. I learn a lot from it because I think endometriosis research is probably about 20 years behind. So with irritable bowel syndrome, I think it was in the 60s or 70s where people started thinking already, well, like there was a lot of stigma and a lot of it's in your head, we do colonoscopy, there's nothing there, so surely you pretend, It's very sort of similar in the sense, but IBS could be described as this itchiness that you feel and it's horrible, but nobody can see. Well, in the 60s they couldn't, but now we see more and more evidence that there is something happening, that there is post-infectious diarrhea, and there's actually not as simple as, in your head. I always think about it that with endo in particular, because there's no test, so you do a blood test or a saliva test and people tell you, oh yes, you have endo. For many years you are treated as if you were simulating this or pretending, but in a way the moment you have a scan that is good quality scan and actually can show it, and again we don't yet have ultrasound scans around the world that have this quality and are easily available. So quite often you do a scan and you say, well, there's nothing there, but if you do a surgery and you see this, suddenly people think, oh yes, and they start believing you because they see this. With IBS they will never see it in a sense that they see it in endo. In endo is a matter of time. At some point people will see this, but by this time your psychological health is already quite shattered, I would say, for the years of of not being believed.
Yes.
So even if at the end you get your yes, you actually were telling the truth, by this time you're already pretty disengaged from the world, and that's sort of sad. So with gastroenterology, we now know that cognitive behavioral therapy antidepressants as well that are called neuromodulators in this context, because they're not necessarily given for mood. And it's the same again with our therapies. When you look for systematic reviews in irritable bowel syndrome, the outcomes are quite often not about anxiety, depression or stress. They're how many bowel movements people had at the beginning and at the end, what kind of level of pain. So you would say the focus is a bit different, and with this behavioral psychological interventions we can change the number of times you go to toilet, which was the disabling thing in your life.
It's pretty amazing.
It is amazing.
It's amazing.
Yes. Yeah. And it's pretty much because the brain and the gut communicate, and I think there's other organs that communicate. It's just that the brain and the gut are particularly strongly connected, and because the serotonin receptors are largely placed in our guts. I can always explain it as a sort of telephone conversation. There's a constant chat between the brain and the gut. So if you just speak to the brain the right way, you can probably impact what gut is doing. And this is what we do with behavioral therapies. We sort of tell the brain to tell the gut to improve itself. And I'm trying to borrow from this and see, can we learn in endometriosis from this conversation? How can we sort of communicate with the brain because all this breathing and other things is telling the brain to calm, to feel safe and do things like that. How do we borrow from the psychogastroenterology and make the life of people with endo better as well?
I think that's such a good idea. I think now we're at a point where we just absolutely need to collaborate with all the specialties.
Agree.
And work out how we can move endometriosis forward, because we've been stuck in the dark ages for too long. So I love that different specialties are collaborating and working out how we can apply those principles to endometriosis care. You talked about the fact that it is really difficult for people to access specialised psychologists or specialised dietitians or whatever it may be, because not everyone has the training, as you say, in this area of care. So if someone is sitting at home and thinks, right, actually, I want that. I want to use that as a tool.
Yeah.
I want to feel empowered, but I have absolutely no idea how to access that. What types of things would you say that they can access from home? Are there any online things that they can do?
Look, there's a lot of resources that are, however, not endo-specific. And look, one thing that is now and is very brand new is Quendo offering. I don't know if you've spoken to Jess Taylor, who represents Quendo. They've built this program on this sort of complex education that is available to anyone through their website. So this would be your starting point to sort of learning more about different aspects of endo. If you wanted to say, okay, well, I want to try this CBT, or there's a lot of apps like something like Mood Gym, but again, you can try CBT there. It's not tailored to endometriosis. So what we are doing at Deakin University at the moment, we are doing a lot of these interventions that are tailored, and I've sent you the flyer for one of the study called Code Endo. And this study at the moment pretty much started recruiting just a few weeks ago, so it's very, very fresh. It was presented here at the conference in the morning session with sort of all the modules and what we offer. So if you wanted to explore how CBT versus acceptance commitment therapy, mindfulness, hypnotherapy, how they work, you can do it through the study at this point. It's not open to everyone, so you need to meet the criteria and you're being randomized. But we are hoping that in a matter of 2-3 years, if this study works, this will become available to everyone for free.
Amazing. And just one last question. Another thing that I've been seeing is that there is starting to become a focus on using AI as a therapist. And I think, I have some concerns about that. But one of the benefits is that for people that can't afford to see a therapist or don't have access to a therapist, it's easily available. And one of the things I'm hearing is that young people actually really love to engage with AI therapists. So what do you think about that? Do you think that's the future?
Look, a student of mine, who is now Dr. Colette Nord, she conducted a study in inflammatory bowel disease with AI therapists running mindfulness classes. It was fascinating because, the quality of AI also depends on how much money you have. And we didn't have a lot because it was a student project. So some of these characters, so they look like humans. They don't necessarily behave like humans completely like they would blink too much or not too much or something like that. Interestingly, there's a lot of people who couldn't tell and a lot of people who loved this. Some people said, oh, look, they are robotic. But overall, this was a positive study, quite surprisingly. Look, it wasn't really a therapist that talked with you as AI would probably. And I think there are huge limitations to what AIs can offer in comparison to a human. But if it's an intervention developed by you, you know, we write a protocol for an AI. The AI is there as a face of it. Like we could record myself talking, but the AI is, I don't know, you may identify with the AI more because they may look more similar. You may not like to listen, you know, to a woman of middle age. You know, you might prefer a younger person or.
I hope no one has that.
Oh, well, who knows, you know. But look, I know, for example, in hypnotherapy, some people prefer female voices. They feel safer, you know. So, like, in the programs that we offer, like, for example, part of Code Endo is a hypnotherapy thing. We offer a female and male voice just because people have preferences. Absolutely. Yeah.
Amazing.
So some potential for AI, I think, but I would be careful replacing human therapists. We are very complex beings. Yeah.
I'm glad to hear you say that. I don't want to replace all of us with bots. I think the benefit of, you know, human connection, you know, will still survive.
Absolutely.
Despite AI. Yeah. Amazing. Thank you so much, Professor.
My pleasure.
Thank you so much for coming in to chat to us. That was really, really interesting, and I hope that's
Thank you.
very useful for our listeners as well. Thank you.
Thank you.